Okay, can you hear me? Good, because there's got to be some reason I'm wearing this crazy thing, and hopefully it's so you can hear me. Um, the skeleton, I would like you all to give us a big hand because we need one. Um, so we've got a little deficit here, but that's okay. So this talk is one that is interactive. It originally had no slides. Kamal wanted slides so that you have something you can look at. So there's some that go with it. But it's really for us to think about our musculoskeletal system, how it changes with age, and how we can change what happens to it. Because I completely believe that the physical shape you have today, you will not have tomorrow. The choice is whether or not you'll improve it tomorrow or whether it will decline. And so by putting in some effort in a correct direction, you can positively change. It's a living structure, and form follows function. I was taught that very early in orthopedics. Things happen in the musculoskeletal system depending on what forces, what activities, what movements the skeleton and the muscle do, and that's what changes with time. And we tend to accept the change rather than trying to improve what our deficits are every day. Okay, so that being said, I brought a friend because it's really easier to see the skeleton, to understand what's inside so that we can help ourselves understand our alignment. So in a human skeleton, we are the only species that comes fully upright against gravity. There's no other species. All primates, everything have a forward tilt, and their skeleton actually reflects it. So something I learned in orthopedics, which was really helpful, is if in the old days, if you were building a big church and you didn't have steel and you needed it to stand tall, in order to make that structure stay upright, you would create buttresses on the side of the churches. You can see it everywhere with old building. The Colosseum with arches, they're all a series of buttresses. So the human skeleton actually is completely full of buttresses. So if you start looking at the shapes of the bones and the pelvis and the femur, they're all buttresses. They're curved structures to hold us upright. In our spine, the vertebra, as they go down, the column widens to the base, exactly like the Eiffel Tower. If you handed me a skeleton of a primate, the vertebra would be completely straight because they're not against gravity. So you often wonder, how can they tell what lineage a skeleton is from? If it's in the human line and it was upright against gravity, the vertebra have a Eiffel Tower-like construction. Okay, this is really important because we're responding to gravity every moment we are upright and even while we're sitting. So we want to talk a little bit about what changes with age. There's some things that decrease. Naturally, they're going to change. And these are the ones that we want to focus on. So strength. Obviously, a muscle's ability to move against weight, the strength that it has, it will decline unless that muscle sees work. And there's varying kinds of work muscle can do, and we'll talk a little bit about that later because it's nice to incorporate the varying types of work. We don't always want just work that is concentric, meaning shortening. We want work that's elongating, so we're more upright. Next, flexibility. Each joint that we have in our body, and there's a graph for this, has a specific range of motion that that joint is supposed to be able to do. As we age and we don't use the full range, the joint capsules around the joints become stiff. They contract, they get fibrosis. And when that happens, you begin to lose the full range. If you've lost range of motion, when you're about to fall or are off balance and you don't have flexibility to get a limb quickly in place, you'll fall. If your flexibility is increased, you have a better probability that you can get yourself in the right position to avoid harm. So flexibility is really important as we age. Next, balance. And I've got a long word underneath it. Okay. Balance is a combination of proprioception. So I want us all to do a little experiment. I want you to take your hand and put it out in front of you. And you know where your hand is right now, right? Even if you didn't look at it, you know where it is in space. That is proprioception. It's understanding body position in space. Now, I want you all to close your eyes, keeping your hand out. Take your other hand and put it on top of this hand. Did it increase your ability with your eyes closed to know where that other hand is in space? The tactile feedback. It does. So when something touches the limb, you can open your eyes. When something touches our skin and we feel it, it amplifies proprioception. So how do you think taping an ankle helps a 300-pound lineman not sprain it? That tape is not holding anybody. We all know that, but everybody's is taped. Everybody has kinesio tape all over their body these days. You see them running around, you're like, wow, racing stripes. So how does it work? Why would tape help? What happens is tape in an appropriate alignment, when you move, it pulls on your skin. And you know where that limb is in space by that tactile feedback of that tape. So it helps you use your muscles to put yourself in better alignment just by having the tape on. The ankle tape. The lineman is playing football. He's on the line. His ankle's about to roll. He feels the tape at a sub-thought level, knows where his ankle is, and he's out of space from proprioception, and takes all the muscle mass of a 300-pound lineman and moves his foot back in the right place. That's how proprioception works. And it's extremely important. If you are injured, break a bone, sprain an ankle, hurt yourself, it damages proprioceptive feedback. It makes it where you can't tell anymore where you are in space. There's a study that shows that if you sprain your ankle and you get physical therapy to retrain your proprioception, which you can do, therapists can help us learn to retrain proprioception. If you do that versus don't do that, what do you think the difference in rate of re-injury is for somebody? Twice as much, 3 times? It's 6 times. 6 times higher to resprain your ankle unless you retrain your proprioception. So everybody, when they have an injury, should have somebody help them retrain proprioception. And then we get less likely to get hurt. Therapists are our best friends in orthopedics. When I operate on somebody, cut in, do damage to fix something, I can actually make you worse before I make you better. Because I've gone into the tissue with a knife, with a drill, with plates and screws, and then I've realigned everything, but I've harmed the tissue to get in there. There's no other way to do it. So what does a therapist do? The therapist will train you to re-heal that tissue. It's rehabilitation and the work that the patient does. And I always tell them that. You got to do the work now. I got you back together. Now you've got to do the work. So balance and proprioception's in the middle because it is so important. Next, endurance. And we all know this. The distance you used to walk or the thing you used to do that seems so easy, as we age, you're like, gosh, why is this so hard today? And it's our endurance is going down. We're not pushing the system to the place where it then gets stronger and has more endurance. We're accepting where we are, and the next day it can decrease. So this can increase with work. You don't have to do 500 more push-ups. You don't have to do 5 more push-ups. My son says, I said, I want to be able to do more push-ups. He's in residency for rehabilitation, sports med, and he said, Mom, to do more push-ups, you have to do more push-ups. I was like, when did you get so smart? All right, next, power. Now, this is one we don't think of as something that we need. We don't need to be powerful when we're aging, but we do, because power is explosive energy. So there's a tack on my chair, and I go to sit on the chair. I want to come off that pretty fast. So power is the ability to have a burst of strength against gravity. So practicing every day, a chair behind you, and I'd like for you guys to join me in this one. Let's stand up if you can. If you can't, or you don't have something in front of you, or not a cane, use your chair, okay? Now, what we're going to do is we're going to act as though we're going to sit in the chair, but don't sit. Your bottom is going to touch the chair, and you're going to come back up. Was that difficult? Yes, because we've conditioned ourselves that we then just let go and sit. And as we age, independence, to get up and down from a chair, to be in the restroom by yourself without someone helping you, that you can go in there and get out of there safely, means that you have to be able to control this up and down movement. So if everybody in this room took a couple minutes every day with a chair behind you of whatever height you feel you can manage this, because the lower the chair, the harder this is, and just stand with the chair behind you, act as though you're going to sit on it, and then come back up. Use your backside to push yourself up. That's power. If you can put your arms out in front of you when you do it, it's harder, but it's better work. So you guys are welcome to sit down, but that is an activity. I promise you, I do that every day. In yoga, that's chair pose. In Tai Chi, there are many things that move you through the full range of motion for your flexibility, that make you stand on one limb for your balance, that have a sequence that you must go through or should go through for your endurance, that make you stand against gravity for strength. And proprioceptively, you'll even watch some people, they're masterful. Their eyes are closed while they're moving. So that exercise is actually one of the few that's been shown to decrease fractures because it incorporates all of these. And I bring it up because in Hawaii, I think we have access to this more because culturally many people here do this. And yoga is another thing that's very popular in our community. And so looking to some of these sports to begin trying to figure out which one of these in you is your Achilles heel. And then work some activity that you like for that one. Then what I would do is rank the next one that I need to work on, and I would pick a different activity. And I would start alternating activities so that I could touch each one of these with something I found fun. And that's a way to make exercise not a burden. Endurance could be walking. If you're super ambitious and you want to make it running, you can. But by our age and our body condition, wherever we start, whatever I have today, I tell myself this all the time, I won't have tomorrow. It depends what I put into it as to what I can do to change it. All right, now, we're going to get a little bit more detail. These are the things that can increase. And I think many of you, being at this mini medical school, you're here because you seek these things. And I think most of you reflect these things. So as I've aged, I tell myself if I was a parent now, I would be a better parent than I was at the age that I really was a parent. Because I think these are increasing. Compassion to other people, empathy, knowledge applied appropriately, which is wisdom. And people that I know that are older than me, they reflect these things and remind me that while the other ones may decrease, these can increase until the day I pass. And so that makes me have goosebumps because those are the things that make us better human beings. So I'm going to take the MSK stuff and make it better and work on these from my mindfulness. Okay, now we're going to get into some technical things. Okay, this skeleton has 3 dimensions to it. Remember in mathematics when we were younger, there was an X, Y, and Z axis that we had to learn in math? That's exactly the same concept we want to think about with our body. So we're used to thinking, because we look at people straight on, we're used to thinking about this plane. This is the frontal plane. It's the front of my body. The slices through a frontal plane go through like this. In medicine, we call these coronal sequences on a CAT scan or an MRI because it's through your crown like a slice. So you would see an image or a piece going from front to back or back to front, and that would be the frontal or coronal plane. Does that make sense to everybody? Because it's important. So if I'm off here or here, I'm off in this plane. I'm not centered over my spot of balance. And in a human being, right where the set screw is on the top of the skeleton, which is the very top of my head, if I'm standing in anatomic position, which means my hands are forward, and this is how all images are taken by convention, the weight and the balance should go from the center of the top of my head to just in front of your sacrum. Okay. This is your cervical spine. Turning your head side to side, that's your C-spine. Nodding yes and no, C-spine. This, with the rib cage on it, is our thoracic spine. The thorax is very rigid with ribs on it to protect heart and lungs inside, and it doesn't have as much movement. Most of the movement is this movement, side to side. And the facets in the back, part of the body of the vertebra, move like this. Where the C-spine, they move like this, forms following function. Lumbar vertebra, really important. Lumbar vertebra don't have ribs attached to them. These facets are oriented like this, which allow me to do this. So forward and back, that's my lumbar spine. Side to side, that's my thoracic. Looking right to left like an owl, that's my C-spine. Sacrum is this little bone grouping all together that looks like a cup. You can see it's kind of curved, and I encourage you afterwards to come look at the skeleton more because you'll understand. The spot where this pole goes through the skeleton is not an accident. It's right in front of S2. So when I'm standing, that's where I want my balance. Head to heel like steel, from top of your head to sacrum. Okay, now we're going to change planes. Same drawing. Next slide. Okay, we talked about the frontal plane. Now what we want to talk about is this plane. When I turn sideways, your head and your sacrum is still your balance point. But you can see the spine is not a total straight line. It's a series of curves that are natural. When I examine a baby who's a non-walker, they don't have these curves. Fetal children or babies or 1-year-olds, their spines are just like this. They don't walk yet. It's when we begin walking. I can tell if it's a walking child by the lateral of the spine. So all I have to do is look at the bones and I can tell you if they walk or not. If they have cerebral palsy and they don't walk, they won't have this curve. This part of the cervical spine curves this way. Can you see that? And I'm going to draw. I'm bringing up more drawings for you. Your thoracic spine, where your ribs are, has kyphosis. It goes forward. As we age, it frequently, especially as women, goes forward too much. There is too much kyphosis if you're leaning forward. Because now, If I'm leaning forward with kyphosis, as an older woman might, then my head is now not over S2. And because of that, my glutes have to work to hold me up. So I have to use more muscle force to stand. I'm spending energy. Can you guys see over here? Okay. All right. Sagittal plane, head over S2 with lordosis, kyphosis. Lumbar spine has a little sway, a little lordosis, like an L. Okay. And then sacrum, kyphosis. And when you draw a line between those lines, you get a straight skeleton. So sagittal plane, nobody ever talked about, and it's extremely, extremely important. And I want you to start thinking of yourself in the sagittal plane. When you're thinking of yourself from the side, is your head centered over your pelvis? Or are you letting yourself roll forward? Or are you letting your pelvis sway back? All of those cost you more energy and are causing harm to the skeleton and discomfort. Okay, last plane is one that not many people think about. And it's an axial or transverse plane. It's the z-axis. It's the spin side to side. Body wants to stay head centered over S2. So if I'm rotated at the shoulder forward here, my body naturally will rotate my hip back to keep me balanced. So leading too far with your body when you're moving in that plane costs a lot of energy. So XYZ, we've got this coronal plane, the side sagittal plane, side and sagittal, both S words. And then you've got your transverse plane, and those are the axial images. That's like slicing us like bread loaf. That's what an axial image is. And that's how you look at a CT scan, as though the patient went in an anatomic position from head to toe, and right side is right side. Now it's much easier to read the scan. You know how they took the image. Okay. This is the definition of lordosis. The word's important because the lumbar spine has a little bit of a sway to it. But if it has excessive sway, like I'm arching my back, that is called lordosis, increased lordosis. And too much increased lordosis, where I'm dumping myself back like this, I'm loading up the facets of my lumbar vertebra, and I'm causing them to take weight, like wedging weight into them, and it causes arthritis. So if you have a weak core, and you let your belly stick out, and you stand with a big sway in your backside, and you load up your lumbar facets, it's why over 90% of adult humans have some facet disease in their lumbar spine from loading our spine. Now, if you have a strong core and you lean back, you don't load the facets. You actually recruit going up. And that's the secret of every diver, gymnast, anyone that does an activity where they throw backwards. They don't throw back, they throw up before they go back. Okay. Kyphosis, probably a lot of you have heard that term. That again is this movement here. And kyphosis, a lot of it is as young women, and sometimes as men, we haven't developed a lot of strength in our back. We have more strength in the muscles that we work in the front of our body, our pecs, our biceps, our deltoids, but we haven't built the strength that's in our back. That back strength is what can keep you from going forward. So having women work on posterior spine strength helps us to get the shoulder back, the sternum up, and keep us out of kyphosis. Some people even kinesiotape across the back of their shoulders so that when they lean forward, it kind of pulls a tiny bit and it reminds them to pull their shoulders back. My sister has very severe osteoporosis. And there's a little device that she bought. She called me, I found the best device ever. I'm like, what are you talking about? She said, it's this little thing. I put it right here. And if I lean forward, it buzzes. Whatever floats your boat. She goes, it really works. It's making me stand up better. I'm like, then go for it. Okay. Now, here's what I was talking about with this sagittal alignment. You can see the cervical spine, try to use the pointer. Cervical spine has a little lordosis. Thoracic spine naturally has kyphosis. Lumbar spine, lordosis, and sacrum, kyphosis. The line from the center of the head to the pelvis will give you perfect normal sagittal alignment of your spine and help you to use the least muscle possible to stand. It isn't that you don't want to use the muscle, it's you want to save the muscle for work. I don't want to be using it while I'm standing in a lecture like this. I'll be fatigued at the end. So this is really important, and I want you to try to kind of visually incorporate. I'm spending a bit of time on this because I think it's probably fundamentally one of the most important things. Here you can see in the frontal and sagittal planes, the line of weight bearing is going from the center of the head to just in front of S2. The sacral vertebrae are numbered 1, 2, 3, 4 as they go down. The second one, that's an imaginary space in front of S2, is the magic spot inside your pelvis where you want the weight bearing to go. So I feel myself grounded on my feet. I feel my head pulling myself upright against the gravity. So I'm tensioning my body because just like a rope that's loose versus a rope that's tensioned, that tensioned rope we can walk on. So you are powerful tensioned by your muscle. When you let yourself crumble, it's weaker. So you want to think about head to floor, eyes closed, I've got balance, and I can stand for a long time. I had to in residency for sure. Okay, now, every big lower body part, joint, has an anti-gravity muscle. It's different in different species because we're the only ones that go upright against gravity. So, this is the butt on fire. That's why it's a red. So, if at the hip, you want to know what is the one muscle that is the anti-gravity muscle, it is your backside, the thing you're sitting on right this second. Okay, everybody up again. Now, imagine you're going to do that exercise we talked about with your head centered over S2, so you're really conscious of your position. And now what I'd like you to do is just slightly lean forward. Can you feel your glute max turn on? Your backside all of a sudden has to kick in because my body and weight are forward. It needs this muscle, glute max, that goes from the back of the pelvis to our leg, from here to here, to hold you up. Everybody understand that one? Okay, you can all sit. So, building glute max strength can be done as easily as leaning forward with your hands on your shins and just pull yourself back up. Leaning forward and pull yourself back up. That's a glute exercise. Once that's easy, taking weight in your hand and leaning forward with weight and coming back up. And when you come back up, use your glute and pull yourself back, and your glute will begin to get strengthened. People that want to be super strong, they take big weight on a dumbbell, they roll it down the front of their body, their backside's out, and then they pull it up. And that's glute max. You're sitting here thinking, I'm not ever going to be able to do that again. And I would challenge you that I don't believe that. I have actually seen people change their builds with consistent effort, but beginning where you are. I can't pick the dumbbell up. It's too heavy for me. I can take a smaller weight and I can lift it. So I think that that's one way that this anti-gravity muscle can be strengthened and can help us. Okay. Now, the next anti-gravity joint we're going to talk about is our knee. Okay, we're back up again. Okay, I want you to stand with your leg if you can, and I know some people probably have a contracture and that's hard, but I want you to get your leg as straight as possible. And this muscle in the front of your leg, put your hands on your thighs. I want you to wiggle the muscle. Lean slightly forward, keeping your knee straight. You feel how it's loose like jello? Okay? It's turned off when I'm leaning forward. Now what I want you to do, if you can, is act like you're going to squat. And what happens to this muscle? It turns on. This is your quadriceps muscle. Your quads, because there's 4 of them, are the muscles that are anti-gravity at your knee. And even if I just stand here and just like wall sit for a second, I'm really working my quads, squatting a little and coming back up. Can you feel how your quads working? So doing those squats to the chair is going to be anti-gravity for your knee muscle, and that's your quadriceps muscle. Everybody clear on that one? Glute, if I lean forward, now I got to use it to come up. Hip. Knee, bend my knee. Now I got to use it to come up. Does that make sense? Good. Okay, we're going to go on. This one's a weird muscle, the next one coming. The residents have the hardest time understanding this. Okay. So you'll notice that the anti-gravity muscles at these joints just happen to be the biggest muscle in that joint complex. The muscles that are in the front of my hip, and even the glute medius and minimus on the side, which we'll get to in a second, those aren't my biggest muscles. It's my glute max, because it's anti-gravity. My thigh, hamstring's strong, but it's not near as strong as my quad. In a normal human being, quad strength is always more than hamstring. That's a normal phenomenon. Okay, now, when we go down to the ankle, where at your chair, pointing your toe and then pulling it back. Okay, pointing it down like a ballerina is called plantar flexion. I'm flexing toward planting it. I'm the ballerina. It's plantar, toward the floor, planting, flexion. Pulling it back is dorsiflexion. Okay, and we'll get to some of these flexion extension words because it's good to know. So, what I need to stand up at my ankle is I need to pull my shin, my tibia, back, right? That helps me get my knee straight. So this muscle, which is our calf, if you put your hand in the back of your leg and squeeze your calf. Now, while you're doing that, plant your toe and then move it back. Can you feel your gastroc and soleus moving? There's 3 muscles there. 2 cross the knee and 1 doesn't. When those plant, they push the tibia back, and they are the anti-gravity muscles. So anti-gravity work, which is simple to do, you can do it seated with a weight on your leg of any size, and you're sitting, and we would put the weight on your knee, like you would have it in your lap, and then you would go up on your toe with the weight on your knee. So go up on your tiptoe while you're seated. So you're staying seated, and then you lift yourself onto your toe. Lift your heel up. Yes. See how you're working your calf and down. So picking your toe up and setting it down with weight is work for your calf, as is if I took weight on my shoulders and went up on my toes, this is gastroc. The seated version is soleus. They are both calf strengthening exercises. So an assessment by a therapist when someone's having trouble with balance, strength, and endurance is going through and testing these different muscles and then making a pattern of therapy practice for you to practice on your own. So many times when I have older patients that have balance issues, or I've operated on them for a tumor, because I'm a tumor surgeon besides being peds, I always have them go to therapy to get an assessment and for then the therapist to help them, and then ask them please to do it at home. All right. Single leg stance. Okay, this is a biggie. So in human beings, we stand 2 limbs normally, and we use glute max and our quads and our gastroc soleus like we just talked about. But when I walk, I put one foot forward, I lift the other one up to move forward, and I am in what's called single leg stance. I'm on one foot. Balance is shifted to one side. This is where these muscles come into play. Put your hands on your hips and put them down like this, reaching toward the prominence that's right here. So sort of like a cup on your hips. Okay, let's everybody stand up again because I think this is better to help us understand this muscle. Okay, if you can you put your weight on one leg? You can use the other leg for balance, but put most of your weight on one side. What's happening when I go to single leg stance on the right side, if I'm standing on my right leg, is these muscles, gluteus medius and minimus, going where my hand is from here to here, contract to hold my pelvis up. If I step on one leg and my pelvis drops, they're weak. You'll see, okay, everybody can sit, so nobody's going to fall. When people have gluteus medius and minimus weakness, when they walk like this. Have you seen older people do this? Even some younger people. What's happening is this muscle's weak. So when I go to step on this side, it's weak, and it lets this space open up because it can't pull me that way. So my whole body weight goes that way. My hip goes up. Pelvis rises on the weak side. My body does not accept having my head nod over S2. We already decided that. So I nod my head to the weak side to get myself back in balance. This is a Trendelenburg gait. I sit in the airport and watch people walk, and I'm like, I know what you have. I know what you have. It's a lot of fun. The problem was one day when I did that, a very unusual gait like this, walked up and then sat down next to me. I tried not to do it. And I looked at him and I said, did you have polio when you were young? And he said, in God's name, how do you know that? And I said, because I'm an orthopedic surgeon and I watch you walk over to sit down. People who have polio frequently have quad weakness. So I can remember when I told you to lean forward and you made your quad jiggle and you could turn it off. So you don't have to use your quad to walk if you keep your body weight forward. So what he was doing was putting his hand on his thigh so he could push his knee straight and leaned over it so it stayed off. He never had to use his quad. Anybody with quad weakness that's profound, that's how they'll walk. So it's fascinating that when you start to understand muscles and where they come from and go to, which is called origin, insertion, and how they cross and how they contract, you can understand why moving certain ways causes certain patterns of walking. And once we identify these patterns of either balance or walk, we can change them. We can improve them with strengthening the muscles that are weak, or we can work on balance. If balance from inner ear, from eyesight, from anything is off, we can begin to work on it. It's something we can change. That feels very powerful to me. I feel empowered that I understand so I can make it better, and that's why I love to teach. Because if I teach you about yourself, you can do it for yourself. And then I've shared, and that's what was done with me. Sharing, learning, improving. Okay, we're going to talk a tiny bit about shoulder. How are we doing, Kamal, for time? We have 10 minutes. We're going to have to move. Okay. This is what a shoulder joint looks like. Even without a hand, it's what it looks like. Okay, the shoulder joint, bony-wise, is very unconstrained. Okay, our hip is a ball and socket, so the bone constrains it. But the shoulder is unconstrained, flat joint to give us mobility. The problem is it makes it unstable. So lots of us strengthen this muscle. If you put your hand on your shoulder, like where you got your COVID, influenza, or whatever vaccine you did get, And you feel this muscle, this is our deltoid. It's like a little general's braid that's on his shoulder. And the problem is we use our deltoids a lot to pick our arm up. But this deltoid goes from here on the shoulder blade, which is called the acromion, and it attaches onto the humerus. And when it contracts, it pulls the humerus up because it's above the humerus, the arm bone. Now, there's something that's in this space that I'm pinching every time when I do this. It just happens to be this group of muscles that come from the shoulder blade. I'm going to name them. Supraspinatus, above the spine. Infraspinatus, below the spine. Subscap, underneath the scapula, teres major and minor. That's your rotator cuff. The purpose of that cuff is to have this humerus head stay in this glenoid joint, to stay in this flat thing, so that when I go like this with my arm, that's deltoid I'm using to get it up there, but it won't pull the humerus up into the acromion because that would pinch my rotator cuff. Lots of people who build up strength in their shoulder don't know to strengthen their rotator cuff. CrossFit people come in like weekly for this. They do big, heavy muscles, and they don't do any rotator cuff. And they get impingement because this will pinch this, and the cuff is right there. So you can pinch and tear your rotator cuff. Guys that work, or women, any of us that work way overhead with our arms, like putting cabinets up or anything where we're trying to use our arms over our head, when it hurts in the shoulder when you do that, that's your rotator cuff telling you you're in trouble. Now, there are a series of exercises that can be given to a patient at home to very easily work on rotator cuff strengthening. You can do it with rubber bands, where you've got a TheraBand and you're pulling and pushing both ways. This is rotation, and you can build the strength and decrease impingement. I had 2 partial rotator cuff tears from doing a whole bunch of stuff overhead and worked on my rotator cuff, and I have no rotator cuff problem. That's pretty powerful. All right, spinal alignment's the last thing we're going to cover, and then we'll stop. Core muscle strength is the most important muscle group you can work on. And the reason is you can't strengthen a shoulder or your hips or your lower legs if you're hanging it on a weak core. And core is not just abs ripped up the front, okay? Looks good, but it's not going to help. You have to have the side muscles, the obliques. They're oblique because they go at an angle. And you have to have the back muscles and your glute. You have to have this whole barrel hoop strength so that you don't let that Prosecco belly or beer belly make it where you're loading your lumbar spine. Your whole core is holding you so you can hold your head over your sacrum. So it isn't as though you have to do a billion crunches, but you need to work each of those muscle groups in some way to keep your core strong. If you find you can't move in the normal ranges, what's maybe happening is the joint is getting stiff and you're developing a contracture. If you get an injury to your shoulder, you fall and land on your arm, you didn't break anything, but you fell and now it hurts. The normal thing you will do as a human being is guard it. You guard the shoulder and it will become a frozen shoulder. We all know that one. And I was running and I was not paying attention and tripped, caught my shoe and fell. The little kindergartner at the playground, "Are you okay?" Embarrassed, but I'm fine. But I stuck my hand out to catch myself. No big deal. I got up and ran home. About 3 weeks later, I went to reach back for something. I couldn't reach it. Like, what the heck? I got a frozen shoulder from falling and injuring it because it was sore. I mean, I'm well aware of my musculoskeletal system, and I didn't even know I was doing it. And it got frozen, and I couldn't get all the way back. And with some PT, a single steroid injection just to decrease the inflammation, full range completely back. but it takes being aware of losing the range to go get someone to help you with it. So I would encourage you, if you say, I just can't do that, you might be able to. I will give you a secret. One of the things I'm happiest about in my life and gifted is that I'm married to Dean Shoemaker. That's why we're back, because he's now the dean of the medical school, and he's my husband. We have 3 children. Sam, he won't mind me telling you this, has ankylosing spondylitis, a severe autoimmune disease. He has 2 total shoulders. He has 2 total knees. He also just got his black belt in jiu-jitsu. You can, despite having disease, strengthen your body and keep it strong. And I would encourage you, and I tell you that personal story about him because I watch him work through it and continue to be incredibly strong and think it's because you're doing these things. So we can. When we're injured, hurt, or it's changed, we can change it. The weakness, the countermeasures we've talked about, you want to be strengthening, you want to work on your power, your sit to stand. If you're finding yourself fatigued, you don't have good endurance, you're going to have to encourage yourself to go to the point where you're a little bit tired and then just do a tiny bit more. It's not like you have to do what everybody else does. They say in yoga when I'm there, don't look at your neighbor. Your practice is on your mat. It is for you. Whatever you can do is for you. You decide. But you're stronger than you think you are. How to train muscle, just briefly. When you make a muscle contract, like I'm taking weight in my arms and I'm pulling it up like this. My biceps means 2. There's 2 heads. Triceps, there's 3 heads. The words are not so fancy. Biceps, if I shorten it, that's concentric strength. I am shortening the muscle while I'm working. But if the weight now is here and I let it go down slowly, that is eccentric strength. That is elongating the muscle while it's working. The East Germans figured out how powerful eccentric strengthening was, and they started training their athletes with eccentric muscle strengthening. And they kicked our butts for a period of time till we figure out, a lot of time we thought it was steroids, sometimes it was, but many times it wasn't. It was their training program. Eccentric training is extremely powerful. It also will make the muscle not be short and bulky like concentric. It will make it be long and strong, which is actually what many of us as women want. We don't want bulk. We want strength. And so eccentric strengthening, the weight is in my arm and I let it slowly go out. That's great training. The last one is isometric. Okay, stand up again. All right. I want you to stand here and just tighten up your backside like you're trying to pinch a penny and you're not going to let it fall. That's a ballerina trick. Okay. That exercise that you're doing right now is isometric. Okay, you can relax. You can sit. If your butt's sore tomorrow, it's not my fault. That is, the muscle is staying at one length, but it's contracting. It's isometric, meaning there's no change in length. And it's also good training. So if you incorporate all 3 with your muscle strengthening, concentric, eccentric, and isometric, you're doing work. And you can do it when you're bored in conference like right now, and nobody knows you're exercising. I would smile sometimes in conference. I'm exercising. Okay. So our alignment, our balance, our range of motion, our limb position, we've talked about all of these things and how important they are. The home base, it's our core. And there are muscles deep to this superficial layer, this transverse abdominis, your pelvic floor, your back muscles that are helping with a deeper level of core. Yeah, this is why I'm a pediatric orthopedic surgeon. We all go, oh, until they're angry at me from whatever I'm doing at them and crying like crazy. So flexion of the body is what retakes you to fetal position. Curling up like this, that's flexion. Flexion of my knee, flexion of my hip, flexion of my spine, flexion of my elbows, my fingers, my thumbs in my palm. I'm totally flexed. That's flexion. That's the flexion movement of all the joints. Vitruvian man, this is extension. Okay? And the ultimate expression of extension is actually to raise your hands to the heavens, and that is called supination, and that is maximum extension, which is like, wow, this is amazing. Lucky we live Hawaii. All right. The words, just so you have a few vocabulary things. If you take your limb, this is my midline. We learned about the planes, and this is the midline. And if I take a structure away from the midline, I move my leg out or I move my arm out, it is the same as abducting a child from its parents. You're moving it away from the parent. So when the limb goes out, this is abduction. When you add it back to the body, that's adduction. So to the midline is adduction. Away from the midline is abduction. Fetal is flexion. Hands up is extension. So now the words become something you understand, and that's very helpful. Last but not least, circumduction. Moving in circles when your shoulder's sore, that's still moving. That's combining all the movements, and circumduction of every joint is actually a good thing. It's like stirring and nourishing the cartilage. All right, we're going to stop there and see if you guys have any questions.
Suzanne, thank you for a wonderful hands-on presentation. Where were you when I first started medical school? I would have loved to be taught it like this. I was telling Chang, I've never been taught it like this. That's really awesome.
Good.
We don't have a lot of time, but we have time for maybe 3 questions. I see somebody, Blythe is here.
In the back corner? Could you,
We're going to start here.
where we're going to start? Okay.
Could you talk a little bit about sarcopenia and can you improve that?
Sarcopenia. Can you improve sarcopenia?
Yeah, sarcopenia. So the word sarcomeres are the building units of muscle. And penia of anything, osteopenia, sarcopenia, any of it means decrease in the number of those. So when you lose strength, and there's some diseases that actually do cause true loss of sarcomeres, but most of the time it's not that they're gone. It's actually that they're smaller and they're not strong and they're not working well. So when you stress, sarcomeres function like my hands apart and then reaching to one another, and there's little arms, if you look under the microscope at the fibers, where when they contract, they engage those arms and they pull. So by stressing them carefully, you can encourage them to build strength. So if I biopsied the muscle and looked under the slide at sarcopenia, it would look like small atrophic muscle. It's actually a different color when you operate on it. When you look at healthy muscle, it is beefy, red, dense. And so you can help to change the strength of what sarcomeres you have to become stronger if you work them and strengthen them. Even with diseases that take away things from us, we can actually add back to what we have. You can't replace them. If a neuron's gone, she's gone. But the ones that I have, by mindfulness, can be encouraged to have their path home a little stronger. So does that help? Okay. Other questions? Yes.
When you're dealing with a tight muscle,
muscle, okay.
Can you talk a little bit about like the difference between stretching and strengthening that muscle?
Sure. So tightness can come from the joint capsule around the joint, but that's more fibrous tissue. If you look at it under a microscope and cut that tissue and look at it, the little fibrocytes are long and spindly. When I cut the muscle and look at it, It's actually the sarcomeres and the muscle fibers. So muscle tightness is that the muscle has an origin, and then it has the body of the muscle, and then it has the insertion. And some muscles have long tendinous insertions, and lots of muscles have fascia around the muscle. It's like a fibrous capsule encapsulate, and we're basically covered with fascia, our whole body, and it's connected. So you need to teach that muscle to increase its excursion by gently stretching to the place that you're going to feel it pulling slightly, but then you relax it and then you work it again. And in those slow increases of range, you'll make the muscle elongate and the tissue will actually can change consistency. It's hard to believe, but it can. You don't want to put excessive force on it. Excessive force will tear. And when it tears, even micro tearing, there's an inflammatory process that starts, and then there's pain and inflammation, and then you're set back. Some people that are overachievers, that's what happens. That's why they get stuck. They push it too hard and they create injury, micro injury, and then they get the inflammatory process going, and then they seem further behind and they're very frustrated. It's that you have to learn to listen to your body and go to the point that you can. There's also a technique called peripheral neurofacilitation, where an example of that is I'm trying to work on stretching maybe biceps. So what I do is I actually put my other hand on my arm. Biceps is here here in the front of my arm. And I'm trying to pull my arm up, but I'm pushing away with the other arm. So I'm making the muscle work. Now, when I let the force go, the muscle will relax more. So whatever muscle you're stretching, you engage it to work. And then you take the work away and you'll have slightly increased range. So it's a PT trick. And again, it's something a therapist can help you learn.
Thank you for a very clear presentation. I wondered if you could talk a little bit about scoliosis and how it relates to some of these things you've been talking about.
Absolutely. Okay. We still don't know what causes scoliosis. I mean, there are causes that we do know. If you have an abnormal vertebra, get congenital scoliosis because there's an extra vertebra. Most scoliosis, though, is idiopathic, no known cause, and it tends to run in families. Scoliosis, what it is an abnormality in the frontal plane. So where this head is centered over S2, if you look at a patient with scoliosis, there is an S-shaped curve to their spine. So the thoracic spine usually has a right-sided curve, meaning the apex goes to the right. And to balance your head over S2, the body creates a secondary compensatory curve, which is a left lumbar curve. The thing we didn't early know about scoliosis, it's trying to keep your head centered over S2. It has a primary curve and then a secondary one responding. But it also is a rotational abnormality, so that if I have scoliosis in my chest and have an S-shaped curve, it'll actually take one of my shoulders and roll it forward. And then the other vertebra in the lumbar will roll in the transverse plane like this. So there's a transverse plane abnormality. And when we fix it with surgery, we have to fix all three planes. You have to put screws into the vertebra, rotate them with devices that we have, align the spine, connect it to a rod, and fuse the spine solid. It's not an ideal way to fix anything, to fuse it, to make it become one solid bone. So there's a lot of techniques that are going on right now where we guide the growth to see if we can actually prevent having to fuse it. So there's a capsule summary of scoli.
Time for one last question.
Yes, ma'am.
I was wondering, they say that you should lift weights for increasing your bone density because as you age, your bones get weaker. And I was wondering, how much weight do you lift and what positions to increase your bone density and which parts are most critical?
That's a really, really great question. And actually, people have done so many studies trying to answer this. So there's not one clear answer. First of all, your alignment of your joints and your body whatever you're doing, you have to be in good alignment when you're lifting weight. If you see somebody lifting out of good position, they're actually putting force on the joints and the vertebra and can cause disc herniation and all kinds of things. But I would say, beginning even with your own body weight through all the ranges of motion to see how you do with your range. So it's flexion, extension, abduction, adduction, same with my hip, my knees, my ankles. And then do a light weight. Have a small light weight in your hand and reproduce all the movements. What you're going to find is when you're working tight to your body, you can lift more weight because the lever arm, remember that picture of Atlas with a big pole under a rock trying to move it? And he said, give me a long enough lever and I can move the world. Levers, think of a lever as you're young, you're 6, 7 years old, you're at the playground. There's a teeter-totter that has a really tall center and a really long teeter-totter. And you're like, I want that one. Because the lever on that thing with a fulcrum that's high is powerful and a fun ride. So levers make it where when I'm doing work way out here, I can't do near as much weight as I can here. So if I'm in exercise class and we're lifting weights and they say, get a set of weights, I always have several sets of weights because if I'm doing something here, I can do more weight. If I'm doing something here, I need a light weight. Sometimes even my arm weight, just doing this, it's like holding the pencil when we were kids. Say, could you hold a pencil? How long can you hold it? It's heavy out here if you keep it out for a long time. So the answer is, it depends on where you're starting from. And developing a program, especially for women, for us to increase back strength, back and posterior shoulder, so that it helps me get my shoulders back, my sternum up, and not my shoulders rolled forward. My mother was 5 foot in her beginning part of her life. And when I asked her, why am I so tall? She said, I was saving it for you. But when she passed, Mom was like 4'7", 4'8", something like that. She was big. And she had terrible kyphosis and osteopenia. And my sister does from some surgery that she had. Seeing these women that I love so much suffer from this is partly what has helped me to say, first of all, I'm not going to allow that to happen to myself. I'm the same gene pool from them, but I'm not having this happen. And also trying to educate other people because I think it was so hard for them and caused so much discomfort that I don't want people to have that. The other thing is, many of you in this room have grandkids. Tell your children and grandchildren that the bone bank they're going to use the rest of their lives, they're going to build when they're teens. And you then steal from your bone bank the rest of your life, especially as women. Every time we have a baby, every time we breastfeed, we lose our skeleton to them. So if you work on your vitamin D, calcium intake, and we've got great sunshine, but usually got sunscreen on, so you still may need vitamin D and some calcium, and then stressing your skeleton with work and muscle strength. And I promise I am living proof that you can decrease osteoporosis and kyphosis because I work at it all the time. I have to be strong to be an orthopedic surgeon. So saying to myself, okay, what am I going to do to keep that strength? But I think all of us need to be strong to do the things we do in our lives. Laundry basket's very heavy. Okay,
Suzanne,
it was
thank
really
you
wonderful.
so much.
Oh, sure.
That was really, really wonderful. I don't know if you've noticed, Suzanne, I'm trying to stand a little bit straighter even now. I don't do very well with that, but I'm going to keep trying. Thank
That's
you so
what
much.
all of us need to do. Thank you, guys. It was really wonderful.
Thank you,
I
Suzanne.
appreciate
Thank
it.
you to our friend here.